everybody. I want to thank you for joining us for the Clinical Case Review live stream event today. Clinical Case Review is a monthly live stream program that takes place on the second Wednesday of the month at noon. This series provides a review of clinical cases followed by discussion. Please enter your questions for our speaker in the Q&A box at the bottom of your screen. We will discuss those questions at the conclusion of the presentation. I'd like to introduce our speaker today. Ashley Wild is the Director of Infectious Disease Clinical Programs and Research at Norton Healthcare. She received her Doctor of Pharmacy from Purdue University and completed her infectious diseases residency training at Hartford Hospital in Hartford, Connecticut. She joined Norton Healthcare in 2011 as a clinical pharmacy specialist in infectious diseases. Dr. Wild serves as the Director of the System Antimicrobial Stewardship Program at Norton Healthcare and is the Residency Program Director for an accredited infectious disease pharmacy residency training program. Dr. Wild currently serves as the lead for CASIC, Kentucky Antimicrobial Stewardship Innovation Consortium, a statewide collaboration designed to address the inequities in access to antimicrobial stewardship expertise across the Commonwealth of Kentucky. She has a relevant relationship with Pfizer as a researcher, and this relationship has been successfully mitigated. Thank you for joining us today.
Thank you for that introduction, and I'm very excited to be here today. I'll go ahead and pull up my slides. All right, I'm going to be talking today about something that's very near and dear to my heart, which is antibiotic stewardship or antimicrobial stewardship. As Dr. Jennings said, my name is Ashley Wild, and I'm an infectious diseases pharmacist here at Norton Healthcare. My financial disclosure, as stated before, I have a co-investigator role on a research grant that was funded by Pfizer studying acute respiratory infections. Now, my objectives for today's presentation is that by the end of this session, you should be able to describe the threat of antimicrobial resistance and the need for antimicrobial stewardship, be able to identify common clinical scenarios to apply antimicrobial stewardship principles, as well as describe effective office-based strategies to promote appropriate use of antimicrobials. But before we get into today's cases, I did want to take a minute and stop and talk about what is antimicrobial stewardship, since many of the people in the audience are used to treating certain diseases and diagnoses, but the concept of antibiotic stewardship, particularly in primary care, may be new to some folks. We've done a lot of antimicrobial stewardship in the hospital, where I've done the vast majority of my work, but it's becoming more and more common to talk about antibiotic stewardship in the ambulatory care setting. So at a very high level, antimicrobial stewardship is a programmatic approach to try to optimize infectious diseases clinical outcomes while minimizing unintended consequences of antimicrobial use. And this balance, I've got the scale up there about balancing clinical outcomes and unintended consequences is really challenging in infectious diseases. Since there are many patients who have true infections that need antibiotics, and they get these life-saving antibiotics that help them live long and healthy lives. But there are really true consequences to antibiotic use that we'll talk about here in a minute that end up being a public health crisis. And often when clinicians are trying to decide whether or not somebody needs an antibiotic, they tend to lead on the side of antibiotics just in case, right? They don't have a true reason or true scientific backing to support that prescription, but rather they prescribe antibiotics just in case this patient needed. And part of the reason is that these unintended consequences kind of float around in the back of people's minds. They're either not immediately apparent or immediately considered, or they could become delayed unintended consequences, something that doesn't necessarily immediately backfire, but then backfires down the road. So let's talk about those unintended consequences first. So the first one is pretty straightforward when it comes to antibiotic use. So toxicities, a lot of antibiotic toxicities, and of course, a lot of antibiotic allergies, exposing patients to antibiotics that they didn't need and then subsequently having an allergic reaction is very problematic. In fact, the #1 cause of emergency department visits for adverse drug events are actually from antibiotics. And in adults, 1 out of 5 ED visits for adverse drug events are from antibiotics. It's because of these toxicities as well as allergies that we want to avoid in our patients. Another big unintended consequence of antibiotic use is Clostridioides difficile infection. So these superbacteria that can cause really debilitating diarrhea is exacerbated by antibiotic use. So antibiotics are the #1 cause of C. diff that can be modified. So things like advanced age and immunosuppression are hard to modify, but avoiding antibiotic exposure can prevent C. difficile infections. And C. diff is a big deal in the United States. It's estimated that we have about 500,000 cases in the United States every year. And like I said, I work in the hospital a lot of times. And so we've got a lot of great programs around hand hygiene and isolation and antibiotic stewardship that has really tackled this incidence of C. diff in hospitals and nursing homes. But we're actually seeing now is the incidence is actually increasing in the community. So no longer thinking of C. diff as a bug that debilitates those in nursing homes or hospitals, but rather it's infecting our patients in the community as well. And C. diff can be deadly. So 29,000 people every year in the United States die within 30 days of a C. diff diagnosis, with 15,000 of those being directly attributable to C. diff. So it can be very serious and potentially deadly, which is certainly what we would want to avoid from an unnecessary antibiotic use. And the cost of C. diff in the United States is also dramatic. So we spend about $4.8 billion a year in excess health costs due to C. diff. But these two consequences are certainly unfortunate, but the thing that I really want to talk about is the development of drug-resistant bacteria or multi-drug resistant organisms. So antibiotic resistance is a true public health threat. Antibiotic-resistant bacteria can spread throughout the community regardless of who used which antibiotic. And drug-resistant bacteria are associated with higher mortality rates, longer lengths of stay, and increased cost of care compared to other infections. So we estimate that about 35,000 people in the US die each year from a multi-drug resistant infection. The cost of care is also staggering. So $20 billion alone in excess direct health care because of the cost of taking care of these infections from a multi-drug resistant organism. And an additional $35 billion a year in the United States is lost due to lost productivity. So when I talk about drug resistance and antibiotic resistance and multi-drug resistant organisms, we often talk about bacteria that look like this, right? Where you get a susceptibility profile and almost everything in there is resistant. Now, fortunately, in the community, these types of pathogens aren't very common. We see them more in the hospital where it's usually much more difficult to treat, and we're often using more toxic or last line antibiotics. And it can be really concerning, so much so that this is a picture of me actually reviewing cultures and susceptibilities in the hospital. But once we get to this situation where we don't have almost anything left to treat these patients with, it makes you wonder, like, well, how did this start? And antibiotic resistance like this doesn't start overnight. It doesn't happen due to one course of antibiotics. It happens because of exposure after exposure after exposure, course after course. And a lot of these antibiotic exposures start in the community. Things tend to start out very susceptible, and then we give a few antibiotics. Next thing you know, they're picking up some mechanisms of resistance. And down the road, eventually we end up like things like this. And antimicrobial resistance can undermine everything we do in healthcare. So we can't treat cancer if we can't treat infections. We can't do surgeries if we can't treat infections. It's important to have antibiotics available in our armamentarium to be able to support modern medicine. Now, some other bad news is if you're thinking, well, we'll just make new antibiotics. I mean, some of these, if you're not familiar with, you think, well, these must be fancy new antibiotics, and surely we have more. We'll just use those to treat these drug-resistant infections. And the bad news is always when we talk about the antibiotic pipeline. So the last time we had a new antibiotic class that was available for use in humans was actually discovered in 1984. This figure shows a timeline of when different classes of antibiotics were discovered. And it starts back in 1928 when we first discovered penicillins, but there's been decades where we haven't been able to identify a new class of antibiotics that would be usable in humans. We've had some new antibiotics that have been FDA approved in recent years. However, a lot of those antibiotic companies ended up going bankrupt because there wasn't enough financial support. There wasn't enough use for them. They weren't novel enough to really fill a need. And so we're back in the situation where we don't have significantly new antibiotics to help treat these infections, which makes antimicrobial stewardship so much more important. In fact, last year, I was at an infectious diseases conference, and one of the keynote speakers, when we were talking about the threat of drug-resistant bacteria, they brought up this date, November 14th, 2022. At the time, last fall, this date was just around the corner. And the keynote speaker said that on the 14th of November will mark the 3rd year anniversary since we've had any antibiotics approved. Not even ones that were, even slightly helpful, or maybe even, a drug that had maybe better side effect profiles or something like that. We haven't had any new antibiotics now in over 3 years. It's a very depressing anniversary. So let's talk about antibiotics in the ambulatory setting and see if we can find some opportunities to improve how we use antibiotics to prevent and mitigate some of this resistance. So outpatient antibiotics in the United States, we've got some pretty good data to look at how we use them. And in 2021, it is noted that in the US, we prescribed 211 million courses of antibiotics in the US. That's a lot of antibiotics. And some very smart people are able to capture data and assess antibiotic use and antibiotic appropriateness. And they've been able to quantify how the opportunity to improve antibiotic use in these ambulatory prescriptions. And what they note is that at least 28% of outpatient antibiotic prescriptions are unnecessary, meaning no antibiotic was needed at all. So if you take that 28% and multiply by the 211 million, it's a lot of antibiotics that weren't necessary in the United States. Furthermore, they quantified inappropriate antibiotics, and they noted that up to 50% of antibiotic prescriptions were inappropriate. Now, their definition of inappropriate meant either it was unnecessary use, like the 28% I mentioned in the previous bullet point, or because they had selected the wrong antibiotic, potentially something that was too broad, or they had the wrong dose, or they had the wrong duration, something that was unnecessarily exposing the patient to risk for the treatment of their infection. So 50% of those 211 million antibiotic courses were suboptimal in some way. Now, we generally accept this as normal here in the United States about how often we use antibiotics. But one of the things I like to challenge people to think about when it comes to antibiotic prescribing is, what if we change that word and antibiotics when we were talking about our statistics? What if we change that word antibiotics to chemotherapy? And we were to say up to 50% of chemotherapy is inappropriate. And if I said 28% of patients who received chemotherapy didn't even have cancer, or the doctor ordered the wrong drug and gave you too much chemotherapy, that would be seemingly like completely unsatisfactory. We'd have a lot of concern about, why are we using so much chemotherapy in patients who don't need it? But honestly, we do this with antibiotics on a regular basis, and it's part of our culture of prescribing and how we approach infections and thinking about that risk and benefit, the just in case antibiotics versus the consequences of antibiotics. But there is some good news that the way that we prescribe antibiotic and the rates that we prescribe them in are different depending on different parts of the country. But I have some bad news for those of us who work in Kentucky. The same data from 2021 is shown across the states based off of community antibiotic prescriptions per 1,000 population. And the darker the orange color on this map, the more antibiotics are prescribed. In fact, the state of Kentucky, as part of the Southern Belt, is actually the 5th highest state in the US. We've actually gone down over the years. We used to be number 1, so that's good that we're making some progress there, but still top 5 is not necessarily where we want to be. In 2021, Kentucky had 938 prescriptions per 1,000 population per year, so almost 1 per person, whereas the average across the country was only 636. So we were about 50% higher than national average as far as our Kentucky antibiotic prescription rates. So we know there's a problem. We definitely know there's going to be a problem here in the South. So I wanted to give a couple of examples of how to approach ambulatory antimicrobial stewardship. So I'm going to go through 3 different cases. I'm going to highlight some of these common opportunities, and I'm going to be focusing on the treatments of these cases. So this is not intended to be, a diagnostic conundrum or a challenging case to figure out what's making them sick. I am going to be, as a pharmacist, really focusing in on the treatment side of things. So let's go ahead and jump into case number 1. So case number 1, we have this 76-year-old female who presents to the clinic and saying it hurts like a UTI again. Her past medical history has hypertension, chronic kidney disease, and COPD. Her past social history, not surprisingly, she's a 1-pack per day smoker. And at home, she takes the following listed medications, including lisinopril, tiotropium, and albuterol. She does not note any drug allergies. And when she comes into the office, we take her vital signs. They seem normal. She's afebrile, temperature of 97.6. Her pulse is normal at 73. Respiratory rate and O2 sats are also normal. She does note that she's been experiencing dysuria for the past 24 hours, but denies any flank pain or back pain as well. On physical exam, she has no costovertebral angle tenderness, and so we go with a presumptive diagnosis of acute cystitis. Because she was complaining about it hurts like a UTI again, in reviewing her past medical chart, you notice that she had a urinary tract infection about 3 months prior. Doesn't look like she has a lot of repeated urinary tract infections, but she did have some antibiotics about 3 months ago. And at that time, her creatinine clearance was estimated to be 45 mLs per minute. So based off of looking at her past urine culture and the susceptibilities from there, you go ahead and select to prescribe trimethoprim, sulfamethoxazole, 1 tablet by mouth twice a day for 3 days. Because she recently did have a urinary tract infection and had received antibiotics, you also go ahead and decide to collect a urinalysis and urine culture. She leaves, heads home, and then upon reviewing the chart later, a few days later, you get the full urine culture and susceptibility report back. And this time, you notice things look a little bit different with her urine culture. The first thing you note is that it is positive for an ESBL producing organism. So ESBL is an extended spectrum beta-lactamase. It's a type of enzyme that a lot of gram-negatives can produce that destroy a lot of our beta-lactam antibiotics. So you can see down on the susceptibility reports that a lot of the cephalosporins and penicillins are resistant, which is what you would expect for an ESBL producing organism. You also notice that trimethoprim sulfamethoxazole was resistant this time. You see that there are some IV options here on the susceptibility report, but the oral options here include nitrofurantoin, as well as the Quinolone, so ciprofloxacin and levofloxacin. So after reviewing the patient's case and the susceptibility reports, you go ahead and give her a call. She does note that she's still having dysuria. She doesn't have any other signs of systemic illness, so she's not reporting any nausea, vomiting, fever, chills, that sort of thing. But this case brings us to our very first poll. So now that you have this susceptibility report back, you have to select a treatment option. So what would you recommend to take care of our patient number 1? Would you increase the dose of trimsulfa to 2 double strength tablets twice a day, go from 1 to 2? Do you switch to nitrofurantoin, 100 milligrams twice a day for 5 days? Would you switch to ciprofloxacin, 500 milligrams by mouth twice a day? Or would you refer this patient to an infectious diseases specialist since they now have an ESBL E. coli urinary tract infection? We'll give you a minute to select your choice on the poll. Okay, we have what looks like a pretty even split between 3 options. So for nobody selected option A, which is to increase the dose of trimethoprim. I think that's a good, and we were correct not to select that as an option. So there are some bug drug combinations where we can increase the dose and overcome certain mechanisms of resistance. Unfortunately, trimethoprim sulfamethoxazole with E. coli, it's not one of those situations, making A not a good choice. About a third of you selected B, nitrofurantoin, which I would say is the best choice for our particular patient. For ciprofloxacin, we'll talk about why quinolones may not be ideal for this particular patient population in the coming slides. And D may not be the best choice since we do have options that can quickly take care of this patient that don't necessarily require IV therapy. So when it comes to ciprofloxacin, I do want to take a minute and talk about quinolones since they are such an important class of antibiotics to talk about when it comes to antimicrobial stewardship. So fluoroquinolones have a lot of side effects. The antibiotics that belong to this class include levofloxacin and ciprofloxacin, but less commonly we use moxifloxacin and gemifloxacin. But these all have antibiotic side effects that cross all 4 of these antibiotics. They carry certain black box warnings. So for those of you who aren't familiar with what a black box warning is, this is essentially the highest level of warning that the FDA can put on a drug to make sure that clinicians are aware that these are significant and serious side effects. And quinolones actually carry 4 black box warnings. The first one is tendinitis, including tendon rupture, which is actually very common. Peripheral neuropathy, this can be debilitating and sometimes permanent peripheral neuropathy associated with quinolone use. Central nervous system side effects are also a black box warning. This is particularly problematic in elderly patients. A lot of different CNS side effects can present with quinolones, but one of the most problematic ones in elderly patients in particular is altered mental status. Right, so in the ambulatory care setting, especially of elderly patients, especially those who might already have some underlying cognitive issues, prescribing them a quinolone may even lead to altered mental status that might hinder them to be able to take care of themselves as well. And certainly if we're suspecting that altered mental status has been exacerbated by an underlying infection, then we certainly don't want to make things worse by prescribing a quinolone. And last but not least, there's also a black box warning for myasthenia gravis exacerbations. But there's more side effects than just that. Those are just the ones that have the black box warning on them. Other side effects include Clostridioides difficile infection. So I mentioned earlier that C. diff is one of those unintended consequences of antibiotic use that we really try to mitigate through selection of antibiotics. So not all antibiotics are equal in their risk for developing C. diff. Some antibiotics are more likely to cause it than others, although all antibiotics can put the patient at risk for C. diff, including the antibiotics that we use to treat C. diff. But quinolone antibiotics are high risk. They're associated with a higher propensity to develop Clostridioides difficile infections. They can also cause QTC prolongation, leading to torsades. They can cause dysglycemias in diabetics. And one of the newest side effects that the FDA warned about was aortic aneurysms. So back in 2018, they released a statement to warning people about the association between systemic quinolone use and aortic aneurysms. Certainly for patients with a history of a AAA, we need to be concerned about quinolone use, but they actually said that, patients who have other risk factors like elderly, hypertension, those diseases that are pretty common in a lot of our patients, we should consider using alternatives whenever we can. And certainly this patient who's elderly with hypertension, we should consider alternatives if at all possible. And on the topic of considering alternatives, one of the things I think is most profound about fluoroquinolones and their side effects is that the FDA actually came back in and doubled down about how we need to use these antibiotics. So the FDA actually recommends against use of quinolones for certain indications. Now, quinolones will work for uncomplicated UTIs, COPD exacerbations, and sinusitis. It's not an issue of efficacy. The issue and why the FDA has made this recommendation is because when there are reasonable alternatives, the risks using quinolones, both on the side effect profile, as well as their propensity to develop resistance and that collateral damage that quinolones can cause, does not outweigh the benefits. So I am not aware of any other antibiotic where the FDA has come out and essentially recommended certain stewardship principles, where they come out and say, if you have reasonable alternatives, please do not use these for what are considered more straightforward infections. We need to be preserving quinolones for indications or bacteria when we don't have other options. And that's really pretty impressive when it comes to the FDA going ahead and taking that step to discourage use for certain indications. Now, I do want to touch briefly on nitrofurantoin. If you guys were thinking, well, this person has renal insufficiency and chronic kidney disease, shouldn't I be avoiding nitrofurantoin in this patient? And I did want to make sure that people were aware about some recommendations that have come out a few years ago, but you might be familiar with an old recommendation that was out there that said to avoid nitrofurantoin when the creatinine clearance was less than 60. Now, there was some concern that because in settings of renal insufficiency, nitrofurantoin would not work as well. So nitrofurantoin is an oral antibiotic, but it does not get concentrations anywhere else in the body high enough to treat infections other than the bladder. So it gets very good urinary concentrations. And the idea is that if you had renal insufficiency, perhaps we weren't able to get enough nitrofurantoin into the bladder to be effective. Unfortunately, nitrofurantoin is a very old antibiotic that was approved way before the FDA required really rigorous pharmacokinetic data. And since then, we've been able to get some new data that said, you know what, I think it's going to get effective concentrations, even if we have some element of renal insufficiency. So in 2015, American Geriatric Society had the updated Beers criteria, and they actually recommended reducing that threshold to avoid use to less than 30. This is really great for our elderly patients. Because as we get older, we lose some of that kidney function, and having that little bit wider window to say it's okay using nitrofurantoin in the 30 to 60 and obviously above 60. There might be a little bit higher incidence of side effects, but generally nitrofurantoin side effects tend to be infrequent compared to others. So again, you can use nitrofurantoin. It should work down to a creatinine clearance of at least 30. And one last note on nitrofurantoin before I leave this is that please assess all patients for pyelonephritis before prescribing nitrofurantoin. So when it comes to the treatment of urinary tract infections, nitrofurantoin, just like fosfomycin, get really good urinary concentrations. But when we're thinking about pyelonephritis, you really need to think about antibiotics tissue concentrations. And so the tissue concentrations that we get with nitrofurantoin in the kidneys are not high enough to be really effective. So regardless of their renal function, we should not use nitrofurantoin for the treatment of pyelonephritis. All right, that's all I have to say about quinolones, which I realize is a lot, but let's move on to our second case. Case number 2, we've got a 38-year-old male who presents by saying my throat hurts. This man is relatively healthy, no past medical history, and his social history shows that he's a non-smoker, an occasional drinker, but he's also a first grade teacher, which, there's a lot of sore throats going around in first grade. He does report an allergy to penicillin, though. When we bring him in, we find that he does have a fever of 101.3 or 38.5 degrees Celsius, while the rest of his vital signs are relatively normal. He does not report any cough, but does also endorse a mild headache and some myalgias. And on physical exam, we see that he has a patchy tonsillar exudate. He's got tender anterior cervical lymphadenopathy. And putting everything together with the fever, the lack of cough, the sore throat, the risk factor of exposure to many young children, you go ahead and order a strep test, and it is positive for a point of care group A strep test. Therefore, we work with a presumptive diagnosis of group A streptococcal pharyngitis. Now, before we get into our next poll, which is going to be talking about what should we do to treat this patient, I do want to take a moment and talk about penicillin allergies. So 1 in 10 patients will report penicillin allergy. They've got a penicillin allergy on their chart. Unfortunately, only about 10% of patients who have a reported penicillin allergy actually have a true allergy. So 1 in 10 of people that are on this call today have a penicillin allergy. However, only 1 of those 10 are actually really allergic. And you might think, well, what's the harm in that? Like, no big deal. You're just being careful. Let's be cautious. And obviously, risk mitigation in allergies is important because I don't want to underestimate the consequences of having anaphylactic reactions. But it's important to note that inappropriate penicillin allergy labels are actually harmful. It leads clinicians to use less effective antibiotics or more toxic antibiotics. And then patients with penicillin allergy labels have worse clinical outcomes, including higher mortality overall. Hopefully not from strep infections, but you never know. The consequences of group A strep can be pretty severe. So the good news is that penicillin allergy delabeling is something that anybody can do to some extent. Clinical history is often sufficient to remove penicillin allergy labels. You don't have to be an allergist in order to prove that somebody is not allergic to penicillin. And taking a good detailed clinical history about somebody's allergy experiences can lead us to comfortably make an assessment of whether or not somebody can be penicillin allergy can be delabeled. If you want a good reference on sort of how to do that and what things to ask and how to put it all together, I have this reference here. It's a good refresher on walking through how to assess somebody's penicillin allergy history. So let's do that for our patient, case number 2. So we ask him about his penicillin allergy, and this is what we glean from our conversation. Our patient experienced malaise, chills, as well as a diffuse pruritic rash immediately after receiving IM penicillin for the treatment of syphilis 3 years ago. So pretty recent. We confirmed that he did have penicillin, not any other antibiotic. And then he was able to articulate his experience pretty well. He said that he self-treated with some over-the-counter antihistamines without any issues. He did not require hospitalization or any epinephrine in the management of this reaction. And to the best of his knowledge, he has not received any cephalosporins to date. So with the presumptive diagnosis of group A strep pharyngitis and a history of penicillin allergy that presented as such, my question comes to poll number 2. So which of the following would you recommend for our patient? Would you like to use penicillin, 500 milligrams twice a day for 10 days? Should we give him cephalexin 500 milligrams by mouth twice a day for 10 days? Do you prefer clindamycin 300 milligrams 3 times a day for 10 days? Or would you go with erythromycin 800 milligrams twice a day for 10 days? All right. We've got a pretty good distribution of responses here. So it looks like 29% of you said we'll go with penicillin, 43 said let's give cephalexin, and then we had 1 vote each for clindamycin and erythromycin. So my preferential treatment for this particular patient would be to give cephalexin, and let's talk about why. So in his penicillin allergy history, he did mention that he experienced a rash that was immediate onset after his treatment for syphilis. It still could not be a non-allergic reaction, right? So in the treatment of syphilis, there's not often, but rarely can have a Jerisch-Herxheimer reaction, which causes that malaise and fever and feeling unwell, and sometimes a cutaneous reaction that's non-allergic, but just part of the treatment of syphilis. However, because he endorsed the fact that he had itching as part of it, that suggested that there could have been a histamine release as part of that reaction. So in the setting of what we would do acutely, maybe before prescribing penicillin, again, we might want to have him see an allergist for something like a skin test. Clindamycin and erythromycin, both could be options for this patient. However, they're less ideal for a couple of reasons. First of all is resistance. So with beta-lactams, we don't have to worry about resistance when it comes to the treatment of group A strep, but there is more and more resistance to clindamycin and erythromycin out there. And also side effects. So clindamycin and erythromycin, both are going to cause GI side effects more often than beta-lactams. Clindamycin is also one of our high-risk antibiotics for C. diff, but erythromycin can also bind to modalin receptors in the GI tract. It actually stimulates gastroparesis and can cause significant GI distress. So my preference would be for this patient to be treated with cephalexin. And let's talk a little bit about the evidence of using cephalosporins in penicillin allergic patients, since this comes up a lot. As already mentioned before, prescribers often use other antibiotics other than beta-lactams to avoid giving beta-lactam in penicillin allergic patients. And what I wanted to introduce was a document that I was particularly excited about when they published it last year. And so I want to tell everybody about it, is this practice parameter update. So the American Academy of Allergy, Asthma, and Immunology, in combination with the American College of Asthma and Allergy, Asthma, and Immunology, put together this update on drug allergies. So this document is not specific to beta-lactam or penicillin allergies. However, it does talk a lot about it, since those are very common allergies. And it's really focused on what clinicians should know and what clinicians should do. And it provides a lot of concrete evidence and concrete guidance on how to manage patients with drug allergies. And I wanted to go over a couple of the common scenarios with you, just because they have very specific recommendations that you can then feel really good about the fact that these allergy experts are endorsing this approach. So in patients who present with penicillin allergy, whose allergy history is something that really doesn't sound like an allergy. So they say something like, I had a headache or diarrhea, or they say, my mom's allergic to penicillin and she just has me really worried about it. These are not obviously actual true allergies, and their recommendation is that they recommend against doing any sort of testing in these patients that have a history that's inconsistent with allergy. And you can go ahead and take that penicillin allergy label off their chart. A history alone is sufficient to delabel them. The second scenario I wanted to go over is what they recommend in our patients, and somebody who has a history of an unverified non-anaphylactic reaction. So this happens a lot when patients have a rash, right? We don't know what to make of that rash. A lot of rashes with beta-lactams are non-allergic. Viruses can exacerbate antibiotic-induced rashes. There's a lot of rashes out there when it comes to antibiotics. But they say that you can go ahead and use a cephalosporin without any additional testing or any additional precautions. So any cephalosporin can be prescribed in a patient with a history of an unverified non-anaphylactic reaction. So this person, we're not entirely sure what happened. He didn't seek medical attention. There was no testing done or no clinician review on his allergic reaction. He self-treated. It's okay to go ahead and write for a cephalosporin in this patient without having to do any additional pre-testing. The last scenario I want to point out, which I think is pretty interesting, is that if a patient reports anaphylaxis to penicillin, They actually say that it's okay to use a structurally dissimilar R1 side chain cephalosporin without any testing or additional precautions. So the question of like, can we prescribe a cephalosporin to somebody with a history of anaphylaxis to penicillin is yes, with a caveat that we understand their side chain. So let's talk about this structurally dissimilar R1 side chain for a moment, because it's really important when it comes to infectious diseases pharmacology. So very quickly, this is an overview of both the side-by-side of a penicillin structure as well as a cephalosporin structure. These are beta-lactam antibiotics, so they share this beta-lactam ring structure. And it's important to note that when patients have allergies to beta-lactams, they are not allergic to the beta-lactam ring. They do not develop antibodies to this ring. Therefore, cross-allergenicity between penicillin allergy antibodies and cephalosporins are not there. But you do have to be careful because both penicillins and cephalosporins have this side chain in the R1 position. Cephalosporins also have a side chain in R2, which is located on the far right side of the screen. But this R1 side chain is what we need to think about when we're trying to decide on whether or not we can use a cephalosporin in a penicillin allergic patient. So the similarity in structures in R1 side chains are going to determine whether or not somebody's going to have a high likelihood of cross-reactivity. And as they mentioned, that patients who have an anaphylactic history to penicillin, we want to make sure that those R1 side chains are not identical. So then you have to figure out, well, how do I know if they're identical or not? Well, fortunately, there's a lot of tables out there that you can use as cheat sheets. There's one in this document as well that provides you these nice tables where you can use them in a crosswalk fashion to determine whether or not antibiotics have identical side chains. Okay, so our patient didn't have a history of anaphylaxis, so we don't necessarily have to worry about whether or not their side chains were similar or identical. But I want to point out a few things. So penicillin doesn't have any identical side chains to any cephalosporin, so it's not even on here. But let's say you had a patient with an anaphylactic history to ampicillin. They could articulate that, yes, they had ampicillin and it caused anaphylaxis. You can use this document to say, okay, I need to avoid certain antibiotics since there are designated by the X in red, certain cephalosporins that do have identical side chains. And it just so happens that I've highlighted here, cephalexin and ampicillin do have identical side chains. This is where it gets a little bit trickier, and we want to make sure that we are really trying to figure out which antibiotic somebody got, which antibiotic they had a reaction to. Again, for the most part, if it's non-anaphylactic, we don't need to worry about it, whether or not they got amoxicillin or penicillin. But in somebody who had a history of anaphylaxis, it does matter which drug that they got because the side chains are going to be different. But overall, you can safely assume that somebody who has a history of penicillin allergy can be given, a non-anaphylactic penicillin allergy can be given any cephalosporins. If you have patients with a history of cephalosporin allergy and you want more guidance, that document that I've referenced now in several slides has a lot of guidance on what to do and best practices for management of either cephalosporin allergy and you want to use a penicillin, or they're allergic to one cephalosporin and you want to use another. So in those situations, I encourage you to either review it yourself or reach out to a pharmacist for help. So that brings us to case number 3, which is our 61-year-old female who presents with coughing for about a week. She took some amoxicillin that she had at home and she's had no relief. Her past medical history includes anxiety, depression, and fibromyalgia, and she's an occasional smoker who works from home with no known sick contacts. And she does not have any drug allergies this time. Her vital signs relatively normal, afebrile, heart rate of 75 and O2 saturations and respiratory rate look good. She does have a productive cough. She notes that she's got some yellowish green tinge sputum. She has a sore throat, a mild headache, but denies any shortness of air. And on physical exam, her lungs are clear to auscultation, but because we've got lots of things going around, we go ahead and test her on a combination COVID flu RSV panel, and that point of care test was negative. Given everything together, as far as her clear chest exam, her coughing, and her duration of symptoms, we go with a presumptive diagnosis of acute bronchitis. And this brings us to our third and final poll, which is, which of the following would you recommend for the treatment of our patient? Would you recommend azithromycin 500 milligrams once, followed by 250 milligrams daily for 4 days? Would you give him levofloxacin 500 milligrams daily, doxycycline 100 milligrams twice a day, or give no antibiotics, but rather offer supportive care or symptom management? All right. It looks like nobody selected levofloxacin, so I'm very happy that we scared you off of the Quinolone. So thank you for the quick application of your learning. We did have most people vote for no antibiotics and rather offer supportive care. A couple of votes for azithromycin and doxy, but I would agree with the vast majority of you in this case that no antibiotic or supportive care management only would be optimal. All of these antibiotics are effective for the treatment of respiratory infections and pneumonia. However, the management of acute bronchitis should be what we consider a never diagnosis. We should not be prescribing. So just as a quick review, acute bronchitis is the presence of cough with or without sputum production that lasts usually less than 3 weeks, that starts in the setting of a viral upper respiratory illness. Now, some patients may be coughing still after 3 weeks. Normally, the presentation starts with a dry cough after progressing from upper respiratory infection, turns purulent, and then sometimes patients have lingering cough that can last for weeks and weeks. The presence of purulent sputum or wheezing does not indicate a bacterial infection. Doesn't matter what color it was, doesn't matter what thickness, if it's green, yellow, it does not indicate a bacterial infection. And antibiotic treatment of acute bronchitis is not recommended. There have been lots of studies that looked at the timing, the selection of antibiotics and their impact on a wide variety of clinical outcomes. So antibiotics does not impact the severity of cough. Antibiotics have no impact on the duration of cough, and antibiotics are not efficacious as preventative strategies to prevent things like asthma exacerbations, bronchiolitis, or progression to pneumonia. So overall, antibiotics should not be prescribed for acute bronchitis. And you know what? This is very easy for me to say, right? Putting up a sign like this that say antibiotics don't work for viruses. It's very straightforward from a mechanism of action perspective. However, as I discussed earlier, a lot of patients expect antibiotics, or they're there for antibiotics. We have a culture in the United States that we can get pills that will make us feel better, that can fix us quickly. So rather than talking about the evidence surrounding antibiotics and their lack of efficacy in acute bronchitis, I actually want to take a minute and talk about some office-based strategies that can be done to help set the tone and communicate clearly and communicate positively about antibiotic decision-making around the settings of respiratory illnesses and viruses. And there's a variety of strategies in a different settings that we can talk about. So the first one I want to talk about is pre-visit communication. So before the patient even comes into the office, what can we do to help curb antibiotic use for these upper respiratory infections? And one of the interesting things is that nursing triage ahead of visits can actually dramatically reduce the number of visits and therefore the number of antibiotics for respiratory infections. There was a study at a Kaiser that looked at almost 300,000 calls to a triage nurse. And what they found is that self-care advice was sufficient in 88% of the cases where they did not need a visit, they did not need any other higher level of care, and did not have any complications. That's a lot of care that could have potentially been set up for an antibiotic prescription had they not recommended staying at home. So things like cold symptoms are caused by viruses. Unfortunately, we do not have medicines to cure a cold. If you feel comfortable managing your symptoms at home, you could save yourself a trip to the office. Your symptoms will likely last around 7 to 10 days. That would be for a common cold. If you have bronchitis, you could counsel them that it might be even longer, up to 3 weeks. But if your symptoms become severe, if you prefer a visit now, we're happy to see you right away. So even that pre-visit communication can curb antibiotic use. Also, when it comes to pre-visit communication, setting expectations with the entire practice staff and educating them about antimicrobial stewardship can actually really play a role in how our patients perceive antibiotic decision-making. So even something as simple as discouraging check-in staff from setting unrealistic expectations, where if a patient comes in not feeling well, there's an urge to want to empathize with them and say something like, oh, Dr. So-and-so will get you fixed up right away. You want to offer that, we're here to help you and we can help you. But when it comes to curing viruses, for the most part, we can't. We can also do things around patient education materials, both in waiting rooms and well as in the exam rooms. There's lots of posters and videos and educational content that's available out there to post regarding the appropriate use of antibiotics. And exam room posters have actually been studied clinically to assess their impact on appropriate antibiotic prescribing. And a few years ago, this 12-week study was published that showed in a randomized fashion that offices where they posted these commitment posters in the patient's exam rooms where doctors signed their commitment to only prescribing antibiotics when they will help you, showed that even after controlling for variables, there was a 19.7% reduction, absolute reduction in inappropriate antibiotic prescribings for acute respiratory infections. So just setting the stage, setting the tone for appropriate antibiotic use can help drive those decisions and make patients feel comfortable and confident with those decisions. So a very low-tech solution to a pretty widespread problem. There's also things that clinicians can do to communicate about antibiotic decision-making that will just help that transition from I'm expecting an antibiotic and I'm here for an antibiotic to I'm leaving here with a plan that doesn't necessarily include an antibiotic. So overall, communicating about antibiotic decision-making, patients want to be heard, right? They want to make sure that you've heard everything that they have to say and their concerns have been noted when you make that decision to not prescribe an antibiotic. So something as simple as what I'm hearing you say is, and repeating the main concerns. There's several things that are not necessarily pertinent to antibiotics, but you can also do things like examine the patients, verbally state the pertinent negatives. So when you're doing a lung exam, you can say, the good news is your lungs sound clear and you are not wheezing. That helps them hear what you're finding on your end. Patients, when they see you for respiratory infections, they want to have their feelings validated. When you say things like, it's just a virus, right? You think you might be communicating and therefore antibiotics are not needed, but saying it's just a virus can be dismissive that you don't sympathize with their feelings of being unwell. So even something as simple as, I'm glad you came in today. I'm sorry you're not feeling well. Sounds like you're not feeling well. Let me see how I can help. Means that you both heard them and that you have really understood what they're experiencing. But then it leads you to the opportunity to have a really positive discussion about antibiotic non-use. So instead of saying something like, you just have a virus, you don't need an antibiotic, you can frame it up and say, the good news is that you do not need an antibiotic. Fortunately, you do not need an antibiotic. So here are a few other things that I can offer. You can state what you know about antibiotic side effects. So we now know that sometimes antibiotics can cause more problems like diarrhea. The good news is I can offer you a couple of good options today. People who train in patient communication often like to use the comparative description of treatment options to say, antibiotics will not make you feel better. However, these options will help you feel better faster. So that way you've not just dismissed antibiotics as an option, but you are clearly stating that antibiotics will not help you feel better, but these things will. If a patient confronts you about the fact that maybe you did prescribe an antibiotic the last time you had similar symptoms, it's okay to say, there's new evidence showing that these antibiotics are causing more harm than we used to think, and I have to be more careful about how we prescribe antibiotics and talk about severe diarrhea as sometimes a consequence of antibiotics that you're looking to avoid, and you're looking to be more careful in protecting their health. And last but not least, when communicating about antibiotic decision-making, make sure that the patients know when they will get better and when they need to return for medical attention. So setting expectations on how long it's going to take for them to fully recover, what to do if they have severe symptoms, where to go, and that sort of thing as well. Now, there are plenty of resources out there about treatment of acute bronchitis, over-the-counter medications and prescription medications, even recommendations on using honey for those that are over 1 as a cough suppressant. You can find some of these viral illness symptom relief sort of prescription pads, if you will. It's great to make sure that patients understand which medications they should be taking. I will tell you the cold and flu industry does a terrible job trying to help patients self-manage with over-the-counter medications. There are so many cough and cold and flu, and they have a bunch of mixes of ingredients that are very confusing. So if you can be as prescriptive as possible to let them know for this particular symptom, this is what's going to make you feel better and how to take those medications, it will go a long way for patients to actually help themselves feel better rather than just taking something that may not even be treating or can make worse some of their symptoms. Lastly, I do want to point out that there are some post-visit office communication strategies that you can think about as well. So at the time of checkout, if the patient is leaving really frustrated, the checkout staff can be educated or prompted on how to respond to some of their comments. So if the patient says, the last time I had this illness, antibiotics cleared it up right away. Even something as basic as understanding that most colds are caused by viruses and do not require antibiotics can reinforce the fact that we did the right thing for its patient. I can't believe they wouldn't prescribe me an antibiotic can be responded by, well, at least you don't have to worry about the nasty side effects they can cause. If a patient says this appointment was a waste of time, an appropriate response could be something like, it's still good that you came in. It's always reassuring to know that you don't have something more serious going on. Or if they say, I guess I'll have to go somewhere else to get what I need, you can say, I'm sorry you're dissatisfied with your care. I can assure you that Dr. X is committed to providing the best patient care, and sometimes antibiotics can cause more harm than good. So simply stating that there is that balance, and then sometimes the side effects, when the benefit is nothing, can cause people to tip their perceptions. So I hope you understand that antibiotic stewardship is for all. I leave this quote up here, no snowflake in an avalanche ever feels responsible, because that's what it feels like, an avalanche of antibiotic prescriptions in the community. And make sure you're self-reflecting on your antibiotic use. Because unfortunately, if you think, well, I don't write that many antibiotics, it does add to the overall threat of drug-resistant bacteria out there. And if you want stewardship in the ambulatory setting, or if you want to self-educate, get some additional research, I highly encourage you to go to the CDC's website. They have some great graphics and some great videos and all sorts of other cheat sheets as part of their Be Antibiotics Aware campaign. They also have a toolkit for implementation of antimicrobial stewardship in outpatient facilities at this web link there. Another great agency to look for more information is AHRQ, which is the Agency for Healthcare Research and Quality. They have a whole toolkit as well to improve antibiotic use in ambulatory care, including things like education and communication strategies, but also true clinical pearls on when we should be avoiding antibiotics and why, and the science behind it. AHRQ focuses on their strategy of the 4 movements of antibiotic decision-making in ambulatory care. So it teaches each of these disease states in the sense of those 4 moments, where moment 1 is, does my patient have an infection that requires antibiotics? Do I need to order any additional diagnostic tests to help make that determination? Moment 3 is, if antibiotics are indicated, what is the narrowest, safest, and shortest regimen I can prescribe? And moment 4 is, does my patient understand what to expect and the follow-up plan? So those are the 4 moments to really think and focus in on antibiotic prescribing. And last but not least, I do want to mention that here at Norton Healthcare, I lead our KSIC program, which is Kentucky Antimicrobial Stewardship Innovation Consortium. You can go to our website or get the QR code there that links to our website. We have a lot of information out there as well, and we're constantly generating more information. If you have a specific question, if you need some educational materials, or you want something created specific for you, go to the website, you can submit your question, and we'll help create something for you to meet your specific request as well. And with that, I thank you for your time and attention, and I'm happy to turn it over for any questions.
Thank you, Ashley. That was great. So there are a couple questions that are in the chat, and I will get to those, but I do have one question that I thought of when you were talking about the penicillin allergies. And I often, and I don't know that I ever found any supporting evidence for it, but I often figured that most of the penicillin allergies, it was a viral exanthome from a viral sore throat that the patient had. And so they got this fine rash that they attributed to an allergy to penicillin, which they didn't need the penicillin in the first place. And now they think they have a penicillin allergy. So it's really sort of 2 harms come from one single act. Is there literature out there that states that's a common reason for people believing that they have a penicillin allergy?
Oh, absolutely. And, it's especially problem in pediatrics, those eruptions that are essentially benign. And when I'm taking an allergy history, we like to ask open-ended questions. And we ask for those descriptions of what happened, what were you taking it for? And really, when I'm trying to differentiate between whether I think a rash is going to be allergic rash or not, I wait for them to say something about whether or not they experience any itching. Because a drug eruption from a viral illness is less likely to be pruritic. But usually I don't ask them that direct questions like, is it itchy? Because I think that leads them to saying yes, because they're trying to describe something it was bad, even if it was diffuse and it was very problematic cosmetically, that doesn't necessarily mean it's allergic. I do also want to make sure people understand if they say things like, I had a rash and it also involved mucous membranes, then that's not an allergic reaction, but rather something that's more suggestive of Stevens-Johnson, which is a completely other type of reaction. So I really focused on, what is an IgE-mediated reaction, but there's other types of drug reactions that this document that I mentioned about, it's safe to give this as long if this does not apply to people who have like leukocytoclastic vasculitis, hepatitis, serum sickness, these non-IgE mediated reactions that you can't just blow off and be like, well, that's fine, that's not anaphylaxis. But when we talk about things like rashes from having viruses, also patients can grow in and out of allergies, at any point in their life. And so when patients report having allergic reaction or a rash decades ago, but anything more than 5 years ago, you're going to want to say like, this is probably unlikely to be, or it's less likely to be relevant now.
So from the chat, when it comes to preventing the development of drug-resistant bacteria, many were taught that taking incomplete courses of antibiotics can select for drug-resistant bacteria. Does this mean that longer courses of antibiotics are better for preventing resistance? Yeah,
that's a difficult question to answer as far as like, what is the right amount of antibiotics? Because the idea that if you halfway treat an infection and that immediately results in the infection coming right back, there is concern that you have selected for some of those more resistant subvariants. However, the dogma about we got to go after every last one of those bacteria has really been debunked with a lot of literature. So these long courses, adding on an extra week just in case, or extending them farther than what's recommended. We joke because sometimes people will say it's like, well, I recommend 5 days of therapy for community-acquired pneumonia, and the prescriber will be like, okay, you say 5, I'll make it 7, right? I just want to add a little bit more just in case. But there's actually a lot of literature showing that shorter is better. In fact, if you Google shorter is better, it'll bring up a website by Dr. Brad Spellberg, who's the chief medical officer and infectious diseases physician out in LA County. And then he collates this really nice table about all the studies showing that shorter is actually better. And every day of antibiotics that we give that's unnecessary drives antibiotic resistance. So anytime we are using an antibiotic, we really should focus on what is the shortest effective duration. Now, that being said, if somebody doesn't take their full course, that's going to be problematic as well. But when you see a recommendation for a certain duration, try not to add on extra antibiotics, even if it makes you feel uncomfortable, because the data really does support that shorter is better for the vast majority of these infections.
Thank you. So the last question that I see in our last 3 minutes, I think we can get this taken care of. So many of us were taught that there's a 5 to 10% cross-reactivity between cephalosporins and penicillins. And I know you talked a lot about that, but where does that number come from, that 5 to 10%? And is that a valid number that has been researched, or is it something that somebody in the 60s made up and now we just sort of live with that's the number?
Yeah, I think you're actually right on the decades. I think it was when the first cephalosporins came out, people were thrilled because, penicillins are amazing. They're so effective. They're so safe. And when cephalosporins came out, those first generation cephalosporins, they thought, well, here's an antibiotic that we can use in penicillin allergic patients. And a lot of patients did just fine. But then they started noticing that some patients that were penicillin allergic were allergic to cephalosporins as well. And what was really problematic about that literature when they tried to look at cross-reactivity was they included side effects that were not allergies. So in these big demographic studies, they included things like GI side effects or rashes that were not allergic. And then they published this early data, I think back in the 60s and 70s, that said, yeah, it's about I think somewhere around like 7 or 8% cross-reactivity rate in these 2 big studies. And people kind of just adopted that. Yeah, there's this cross-reactivity rate. But unfortunately, even in their studies, they say this is not conclusive that there's cross-reactivity. And in fact, what was even more problematic back in the day was that some of these early cephalosporins in the manufacturing process were actually contaminated with small amounts of penicillin. So people who were really penicillin allergic were actually having allergies to these cephalosporins. And so we got this like cross-reactivity rate of 5 to 10% has been carried forward quite a bit. But in reality, modern allergy studies show that the likelihood of cross-reactivity when you have dissimilar side chains, the cross-reactivity of it is likely nil. Now, that being said, some people have allergies to multiple things, right? You might be allergic to strawberries and bees and penicillin, and those people might have allergies to other non-related antibiotics, including cephalosporins. But there's this really good reference article that I point people to by Michael Picacaro, who I think is a pediatric specialist. It's a few years old now, but he actually talks about in support of the American Academy of Pediatrics position on using cephalosporin in penicillin allergic pediatric patients, about the history of that, the side chains, and really understanding the mechanisms of cross allergenicity. But for the most part, yeah, like that's a comfortable number that people like to think, but it doesn't, it has much more to do with side chains and doesn't have anything to do with the generation of cephalosporins.
Thank you. So I think that helps a lot of people in trying to think through that. So it's time for us to close the program. So this concludes our program. If